All right. Welcome to Planetary Health First, Mars Next. I'm super excited today. We have an amazing guest, Brendan Keeler, and he is here. And we were going to go over all this thing, how we can save the health information exchange and all this stuff. And we will do a particle 2.0, and we will get all this. And he's the right guy. Trust me. I think you know who he is. But share a little more about who you are, real quick, before we do some deep dives.
Sure, yeah. I'm Brendan Keeler. I work in healthcare interoperability my entire career. So worked up at Epic, the large electronic health record system in Madison, mostly abroad in the Netherlands. And then went to work for Redox, helping apps connect to EHRs once they've sold, so business associate applications. Then moved to Zeus Health, run by Jonathan Bush of Athena Health fame, working to help people, provider groups and other softwares access health information exchange. And now I'm at Flexpa. And so Flexpa is flexible payer access. We help via the right of patient access, via patient authorization, patients access their health data from payers, from insurers, so their claims data, and direct it to the applications of their choosing. So we provide the broadest access there, and it's really empowering to help patients direct data where they want.
That's cool. And in the green room, I guess our room isn't green, but the room before going live, we were having some really good conversations. I wish the good stuff sometimes isn't recorded. So if you could sneak in, we would maybe let you in. But fascinating conversations we were having just about Walmart. We'll talk maybe later about that, just what your thought is. But do we want to share a little more Particle 2.0, the health information exchange, where I know you've put out there a lot, but what would you like to kind of help move this conversation forward on?
Yeah, I think just like the high level for people who haven't been paying attention to it is that health information exchange in America is here. It's ubiquitous. It's happening for 70% of providers. And we're hitting this point of a ton of stressors where people want access to data. And so now is the time to start thinking about how we should do that at a national scale, how we should ensure both there's this liquidity so that data goes where it needs to, so that when I show up at the doctor, they don't have you fill in your chart over and over again, so that when you go to access your patient portal, the results and things that you expect are there, so that you're able to take the data where you want and access it in the application of your choosing. And so that providers and other entities, other businesses, labs and pharma and life insurance, and everyone that has some need or adjacency to health data can access it at the right place at the right time. We're not there yet. We're only fractionally there in terms of providers being able to access data. But if we don't start thinking about it at a national ecosystem and infrastructure scale, we're going to continue to have sort of the crises that we're had in the past couple of weeks with Particle and Epic, sort of in the news with CNBC and these other organizations. So yeah, that's sort of the framing, is that we're getting there. It's no longer each health system sitting in their silo, but they're talking, and there's the chance that it goes really, really right, and we make things the way they should be. But there's also the chance that we have really bad outcomes, abuses of privacy, people selling your data without your consent or your knowledge, in sort of data black markets. I don't think anyone wants that.
So what was that I just saw earlier? I think it was on Friday. Last Friday, it was released about Kaiser had a huge data breach. Did you hear that or see that? How the apps? I guess that's totally how that went wrong.
Yeah, I mean the data breach, and so more with Change Healthcare and Kaiser, we're seeing that there's this turn of focus from hackers towards healthcare. There's a lot of focus from the FTC and other entities on the privacy and security of data. And so, yeah, in addition to allowing for liquidity, allowing for really digital innovation to take place, there's this balance with keeping your shit together, keeping the privacy that we deserve in a time where privacy is needed more than ever because of different threats to what we care about in terms of health data, in terms of women's health, in terms of LGBTQ health, and things that while controversial, there's real impact. And so privacy, already enshrined in HIPAA, already enshrined in some of the rules we have, becomes paramount. And security, protecting against these black hat hackers out of Russia and that are targeting healthcare because healthcare is data rich. So yeah, not to say Kaiser's in the same boat as Change, but these big entities, these big healthcare entities are definitely targets and are definitely suspect to security and privacy problems.
I mean, it's kind of frightening, really, when you think about it, because I know there's this phone called Unplug that's coming out in Israel because of the whole Apple thing, that the iPhone is not doing what they're saying. I mean, I don't mean to, and maybe I'm wrong, but the whole privacy thing that they're saying, that it's so, I'm hearing from other sources that they're doing the same thing as everyone else, selling that data or utilizing you as a product. Have you heard anything about that?
I'm not sure about Apple. Apple, their whole positioning is based around, the data on device, all these techniques to be very privacy forward. So I haven't heard that particular news, but there's definitely more and more scrutiny. And I think that's because of the abuses we've seen, and it's because of the security violations, allowing lots of data to flow where it shouldn't. And it's because there's more data than ever. We have we have everyone, Fitbit's producing data. We have all these wearables producing data. We have health systems adding more and more diagnostics. And there's a demand for data with AI products that need this corpus of data to train and to be accurate. And so, yeah, I think that could be part of it. And I think Apple, it would surprise me that would go against some of their positioning, but everyone has that pull, that gravitational pull.
Yeah, I don't want to be like a conspiratist, but it's something that I had heard, and there was a technology phone that's really working, highly tech. I think it's Unplugged, and they're basically sharing flat out that Apple, everything they're saying is not, this whole we're private, their whole everything that it's sad, and I hate to say it, I mean, it's the trust. I think trust is everything, but the thing is, it seems literally, how is it that you can trust? And so they know where you are. And these apps that are coming through. So just if they don't, I don't know. I think in the end, we're in a world where, as much as HIPAA is amazing and we want to have it where we want to have privacy, but I almost assume that you have no privacy, and it seems awful, and it is. So anyway.
No, I mean, that's called a zero trust security posture, right? Like the traditional security posture for an enterprise is to say, I'm going to build a wall, and anyone inside the wall, I trust, and anyone outside the wall, I don't trust. But that doesn't work for infrastructure within an enterprise. And it doesn't work really for privacy. It doesn't really work for national ecosystems, we're finding out. And so moving to more of a zero trust mentality and being strictly permissioned, you granting your data each time, whenever you want to, having high visibility, high transparency to where your data is and isn't, where it's used, who's accessing it. Only by adding transparency do you overcome that challenge, because the sort of trust is within the walls model doesn't scale in the internet era to any sort of ecosystem. And so I think you're 100% right. That's a really good point.
So what could we do? We came here today to save healthcare information exchange. So what do we need to do, in spite of knowing we need to help the flow, the liquidity, but put the brakes on it to protect the patient and every individual?
So it comes back to like just what we were saying, transparency across every aspect of it. The more you add transparency, the more trust is engendered. If I can see where my data is, if I can see who's accessing it, if I can see who those people are and what they're intending, then suddenly like you allowed for the maximum amount of exchange, but also the maximum amount of visibility, which thwarts any fraud. With a system of exchange, with anything we do, time you build a network, it could be as simple as mail or email or phone. If you build those networks, there's some amount of fraud. If you think about mail, you get spam mail. If you think about email, you get the people trying to get your passwords and stuff. Phone, you get shit calls all the time.
Oh,
So
God.
anytime you build a network, there's going to be abuse.
Mhm.
But building the tooling to assess and address for fraud, building transparency allows for people to help with that, and opaqueness does not. It's as simple as that.
Mhm. Well, I feel like sometimes we need to reinvent healthcare from scratch, from bottom up.
I mean, just the ornate ways we've crafted things in America in terms of insurance. Like starting to work at FlexSpot, I was just surprised. I'm like, oh, like here's how Medicaid really works. Here's how employer-based insurance. But then there's level funded. There's self-funded. There's fully funded. There's within Medicaid, MCOs and fee for service. And you start to break all these fractal pieces apart, and you're like, holy shit, we built up a shitload of complexity. So yeah, like I think it'd be great just to like, whether it's on the insurance side or like whatever the care model side, to sort of like turn over the board and start again. I don't know how realistic that is to have that sort of revolution, but Michael, if you got a path to it, like I'm all for it.
Yeah, I think that's why it was exciting when you're doing like healthcare with like blockchain in Lithuania or Albania, or Finland, all of a population or whatever, 100x smaller than America. It's different, but yeah, I do think, I guess my beef as a patient, that has all these things in my chart. You take my chart and you take Follow Health, which I don't even know who owns or whatever. One of them's Epic, one of them's the other one, who knows, or whatever.
I think it's Athena. I think you're right. I think it's like, or maybe eClinicalWorks.
And they're just not good. I mean, what would be the NPS if you really assess the patients? I mean, it's like they're just not like what I think it's a difference on my health, meaning Mr. Michael Mann's health, and what's his meaningful, what he does to try to improve his health, or those behavioral changes that I'm having to do, really don't have anything to do with my medical record.
Yeah, I mean, I'm a strong proponent of patient portals actually doing the job that patients need and not the job that health systems need patients to do. And I think the user interface is dated, everything that you're highlighting. And so the ONC, the Office of the National Coordinator, the government has for many years been promoting that patients can choose their own application to do certain things. They can access their data through these APIs. And so we're trying to get to that place, and there's certainly been a lot of effort to promote these APIs to allow people to do that, but they still don't do everything you need.
Mm-hmm.
And so you as a patient don't just need to see your clinical data, but you might need to see your appointments. You might need to cancel an appointment. You might need to pay a bill. Those are all routine actions that aren't enabled today. And so we still have a lot of work to do to get to a world where third-party applications that actually have good user interfaces can do the jobs to be done that patients need, like yourself or myself or my daughter.
Yeah, I will say that there are some functions within those that, the texting, if they look at it, or the Teams, is great, but somehow my labs got lost. The data with the other, and I'm like calling, they're telling me to call 1-800 number, and they didn't know anything because they don't know what lab it is. And it's almost comical. And then I'm almost feeling gaslighted. Like, did I have the lab done? Was it scheduled? Was the referral? And it's just like, I'm sure that doesn't happen a lot. But then I was thinking, was that during the time that Change Healthcare happened? I don't know.
Totally. They have a huge lab order and results business. So I think, it could have been. But to your point, infrastructure is not just patient access to a single health system. It's about connecting all the players in healthcare. And so fixing health information exchange, it's not just, let's go fix Epic and Particle and care quality. It's let's figure out these different players, labs and providers, payers, pharma, life insurance, anyone that has a need for a job to be done that's fulfilled with health data in some fashion, and make sure that we have the rails, the infrastructure in digital fashion to accomplish that. And we have some of those nailed and done, and others just completely broken. And so lost lab results, you're like, maybe it doesn't happen. Sure does, all the time. And here's the other thing. If you go to one provider and get a lab done, even though there's interoperability between those providers, it doesn't mean that it's actually those labs are going to provider number 2, unfortunately. So we have to do more. We have to do better and build that infrastructure, those rails at scale nationally, in addition to patient access infrastructure, so that you can choose the application that in the way that you say, oh, this UX helps me in the way I want to be helped.
One thing I'm fascinated about, we have data that peer-to-peer support really helps with diabetes, with, AA is a huge one with mental health. Are there any, and I'm asking you, of course you might not know, but I think you do. Are there any organizations that are putting together through the health exchange to really help empower caregivers, family caregivers? It just seems like all these companies that are doing stuff like that, they're just having to start one by one. But and I guess part of it is I'm tired of being asked, do you smoke? It's like, why don't you ask, are you a caregiver? Are you, three questions that are relevant to me that I'd like to be asked that would make my health better. But I'm sorry, every time, I don't know if it's like a COVID question, but everywhere I go, they ask, do you smoke?
Well, that's from federal mandate, right? That's meaningful use is the legacy trickled down from not to blame Obama. It just happened to happen when his administration, because healthcare technology is bipartisan, but meaningful use was done by the Obama administration. That question, you get a ton of physicians who are gonna be like, oh yeah, I hate that I have to ask that one, or I had to ask that one. But yeah, the healthcare system is not optimized for caregivers, to your point. Proxy access to MyChart and other tools generally sucks, right? Like it's not simple to sign up for a patient portal. It's definitely not simple to sign up as a caregiver and be able to administer care for a dependent or for an older family member. It's like you have to call 6 different lines sometimes. Depends. Some health systems are doing better. And so, yeah, optimizing for proxy access for caregivers and helping them do what they need to. Yeah, there's a ton of people working on that in the small space, but they just definitely haven't been able to, back to the infrastructure point, access the infrastructure to do that job to be done. It's not there yet.
And I also just feel like, AI has been getting so much, it's been covered so much. It's such a huge, and I hate to say it, the money is so much, it's so powerful when you get NVIDIA going up. Like no one had heard of NVIDIA a year ago or two. People did, but as a gamer, it's based on gamers. Thank goodness for gamers, or they wouldn't be around. But AI is taking up this huge space in healthcare, but it seems like there needs to be practical decision-making conversations that can really, I feel like without that, AI is just going to make things worse.
Yeah, everyone's talking about AI. My lens on it is data and infrastructure. My view is that there's 100 different applications of AI. There's going to do some good things. And there's going to be, maybe we regulate them, maybe put in the rules. It's a little beyond me. It's not my focus. But what I do know is that all of AI has a heavy data demand. So it adds this pressure for data, for pulling data, for stressing the infrastructure we already have. And so, yeah, thinking about that and saying, how are we facilitating this novel technology that's going to be demanding data? If they can't get it through legal channels or channels that are, paved paths, they're going to go through ways that aren't paved, that aren't approved, because they have jobs they want to do in the service of helping somebody. And so, given no other option, they'll break the rules. And so we've seen that. That underpins so much of sort of the epic versus particle debate of the past couple of weeks, is a demand for data to solve jobs to be done that are worth solving, but not accomplishable today. And so AI adds that demand for sure.
And AI is going to be, we need the infrastructure for electricity. I hate to say it, we need to have a national grid update. The thing is, we're not going to have enough power to do the computing that's needed.
Luckily we had the Bitcoin guys putting pressure on that for years, right? But yeah, totally.
So, and what I found a little interesting, I know we're really going off topic, forgive me, but what was unfortunate, and I don't know what would have been the perfect time, but going back to, yes, AI is amazing, it can do amazing things, but where I have a frustration is, I guess, not a primary caregiver to my dad who's 91 in hospice, but the decision-making process between the primary care provider, the hospitalist, it took way too long to empower my mom to feel like she had the right decisions. And that just, I mean, I'm telling you, once you're 65, 75, they just, I hate to say it, there's a revenue driven model and not the right care model. And, I don't know how long in hospice, there's orders. So every 6 months you get recertified. But I think 2 years ago, he could have probably been in a better, that could have happened rather than 6 months ago.
Yeah, I mean, hospice care, I think as my only I don't know it that well. I've worked in it. I've worked with EHRs that do hospice care. I've worked with EHRs that do hospice care. And my thought there is that as our population continues to age, right? As we age out America, this is going to become more and more important, that it's not some sort of shoddy place that we're shuttling off, somebody, which it never should have been, but that it's, something that's scaling to larger and larger portions of our population. So I'm optimistic that with that focus, we're going to see improvements. But that's I have the same empathy. I have empathy for what you're saying with numbers.
I guess I should clarify. It's not so hospice. So I was a little confused, and I think it's different in state by state palliative care and how it's connected with hospice. But the little I would say is just, it seems like we need better regulation, better policy, and that would deliver better care outcomes, because it's at a certain point, it was known probably 2 years ago. Let me just say that my dad should not be having aggressive heart surgery or those sort of things, invasive procedures. So call it whatever, but finally the way it was communicated, okay, you are in hospice, you're not going to go to the hospital any longer. And then my mom now had a 24/7 nurse, because it was that frightening moment that really led to, I had to be over there. The paramedics were there. He didn't want to go. The next morning, he finally had enough energy. We put him in the hospital for a few days. He was admitted. And then finally, it was then my mom had a nurse practitioner, palliative care, that gave her all those decisions, educated her. But it was just way long overdue. None of the other, all those visits, no one wanted to have that conversation. So anyway, I'm just putting it out there because I think these are the important things to improve our whole system as we have so many people that are older and frail.
Yeah, I mean, our system is geared towards, we need to solve the problem, right? Like we need to make the person healthy again. So I think hospice in that light, I'm tracking you a little bit better where you're headed. It's really hard to admit defeat, right? That's the way it's viewed is, oh, well, we're saying we can't solve these problems. I think that especially in this, the way we pay for our care incentivizes like, oh, let's do the next level of treatment. Let's go up in intensity. Let's keep pursuing it. And so, yeah, a shift in mindset to understand that that's not always best. It's sort of orthogonal to what we do, the way we've built out our care models with increasing acuity.
Yeah, and I think also, and my mom, it's too much on her too, because she doesn't want to give up either, because that's sort of how the narrative is in our system, just in our ecosystem in the United States. So enough about hospice. I want to talk about how we could reimagine healthcare as you would see it from, what we were talking about with, the data exchange and the health information exchange. What are you seeing that really you think is hopeful, positive about it?
Well, the positive thing is that 70% of providers can exchange data with one another. You can get that basic chart, meds, allergies, problems, sent over digitally and parsed into the EHR or to the tool of their choosing. So that's really cool. I think that's the biggest success of the last 5 years is Care Quality Commonwealth, these networks sort of coming together to offer that. And so that's optimistic, growing that to all providers, making it actually really work, because especially for lower tier EHRs and things like that, they can do it, but it doesn't really work. It doesn't funnel into your onboarding charts or something when you're at the visit, like you mentioned before. And it should. And if you do that, then just it eases all this friction, all this repetitive work that's really costly, and also leads to really bad outcomes that are costly, outcomes that are bad for the patient. And so I think that's optimistic, is that we as a country can. Here's another good one. When you go to a doctor and they say, okay, you need so and so medication, you don't get something printed out and carry it with you anymore. Usually you just go to the CVS or to whatever pharmacy.
Yeah.
E-prescription is ubiquitous. That's
Yeah.
infrastructure behind the scenes. And so some countries don't have that. When I went to the Netherlands, they didn't have that. So we helped start to set that up at the national scale, but it was just like one hospital with one pharmacy at a time. And so we take that for granted. And so, but like, that's awesome to have those pieces of infrastructure, reducing waste, making life easy.
Yeah, I'm glad you brought that up, because you always have to have benchmarks. The 70% is pretty impressive. That's a good data point. And I bet you, what would it have been 10 years ago? I don't know if you have that.
10 years ago, near zero.
Okay. Wow. Okay. So thank you for kind of bringing us back to reality and milestones and where we're at. So hopefully, it will be in the next few years. I mean, are we headed uptick, or is there problems? Tell me.
Yeah, I mean, there's definitely been more and more adoption. And so going back to sort of particle and healthcare, that's the challenge, because just focusing on the one problem of let's have providers communicate back and forth, that's grown tremendously. That's awesome to see. But there's other entities looking at that and saying, oh, I need health data and I'm a payer. Oh, I need health data and I'm a life insurer. Let me just go into those networks and use them. That's not how they were built. And that sort of breaks the trust and privacy that we were talking about. And so that's not to say they shouldn't have access to health data for certain things with the right permissions, but using these networks for providers for other use cases isn't right, because there's all this risk in terms of privacy, in terms of security, in terms of, just like breaking the law. HIPAA is the law. And so I'm not just here to wave a morality flag. I'm here to say, let's serve those use cases. That's the challenge du jour. Like, that's where healthcare needs to go next, is not just expanding to 100% of providers, but helping every actor that has a need for health data with the appropriate consent, with the appropriate things in place, access it when they need to. And that's net new infrastructure and rules to accommodate that.
So what you were talking a little bit that you were worried about some more of the opaque kind of practices.
Yeah, so like just transparency is the way we get there, because as you scale this out, you can't just assume that who's in this circle of trust will be trustworthy. That's not how you do security anymore. If you think about like an enterprise, so if you're a hospital, you don't build a castle and moat. You don't build a castle and moat around your data and say, oh, whoever's inside my network is safe and whoever's outside is not. The internet has forced us to move to a zero trust model, so that you always authenticate. You always have visibility to access of data, access of different applications within your enterprise. And you never trust that anyone is not a bad actor. That model applied at scale to the nation, to our infrastructure, that's what's needed. And that's only accomplishable by transparency, so that you, Michael, could log in and see, here's where my data is across all these institutions. Here's who's accessed it. Here's the providers or the payers or the life insurers. And you could say, wait a minute, who the hell is National Life Insurance? You could identify these things and or you could see everything's great. Everything's going as I planned. And that builds trust. Transparency builds trust. It's like the one call to action that we have is to just build that transparency across every facet of interoperability and health information exchange. Because if we do that, then you as a patient can feel that your data is being used when you want it, where you want it, by who you want.
So I feel like you're also talking about ownership, or not ownership, but rights, maybe is a better word. The rights to be informed, better consent, like a higher level of consent, because I think using the lab information, I don't know. No one knows. Like I know I had my blood work done in this year, 2024 January, but no one knows where it went. So with what you're saying, they would have some way to track those breadcrumbs.
Yeah, I mean, consent's already there. Like HIPAA demands it. All these things demand it, and you have the right to your data. So like those things, the government has been really good at nailing something on the wall multiple times with HIPAA, with Cures Act, with all these different regulations. But what actually is needed is is transparency by these actors towards patients in terms of data, but also where the other actors accessing your data. And so not just knowing, okay, here's my meds, allergies, and problems, but also saying, okay, here's all the people that have been using it. And by seeing that, you can say, I know that so-and-so doctor used this. Maybe there's the lab results over there. Or you could say, okay, my payer has accessed my data. I know that they're trying to do certain things to help me.
Mm-hmm. Well, so what is like, I know we've talked about the particle, the epic. Tell us, for the people who haven't been up on it, just like the sixth grade reading level, what the heck that was. I know it seems, is it up to debate? Is it still debatable? I mean, it seems like it, or is it totally clear what happened?
It's not totally clear, but at a high level, what happened is we have these networks that allow for providers to exchange with other providers. Epic allows their providers to exchange with other providers across these networks. Particle, an on-ramp to the networks, they help other groups join the networks, also allows some providers to participate. Epic shut off access to Particle a couple of weeks ago, and that's because they believe that some of the people, the actors, the businesses that Particle was helping were not providers. They were doing something else. And so they weren't fulfilling the rules of the network. And so the open question, the care quality the network is figuring out is that true? Did their customers access data that weren't providers and thus maybe break HIPAA? Did they knowingly facilitate that? Did they go and sell with that angle? That'd be extra bad. Or are they falsely accused? Did Epic turn them off wrongfully? All these are real possibilities, and that's what's being figured out. And it's difficult to untangle because it highlights something that's true, that there are bad actors on these networks that are doing those things, that are not providers. And so we can try and police these networks more and more. We can say, oh, let's try and find all the non-providers. Or we can say, how do we build a way for non-providers, for lawyers, for life insurance, for the patient themselves, for all these different use cases to access data appropriately? And that's the right answer. And that comes by figuring that out, building paved paths, and then building it transparently so that the patient can audit, understand, and be a police on the individual level, the traffic, to maintain their rights.
So what would have to happen to make that work?
So I think the leaders of care quality of Commonwealth, these big networks, and then TEFCA, the Trusted Exchange Framework and Common Agreement, which is the U.S. government trying to promote the next iteration of these networks, they would have to come and they'd have to make those rules real and get adoption. So they can write all the rules that they want, but if no one adopts it and follows them, then they're fake. Mm-hmm. And so the challenge, because TEFCA did just release their version 2 rules, the challenge for them is to grow and become 70% of providers or 75% of providers using the new framework, and then facilitating those paved paths of exchange. And if they do so, we're in a better place. We can continue to see all the sort of problems you were highlighting of the patient portal not having your lab results, or other data being missing, or you having to fill in the same forms. Over time, that's just going to go away. It's going to be like e-prescribing. And so we get there, we're able to overcome this challenge. We get to that point where there isn't that friction. It's just in the back of your head. You're like, oh yeah, that used to be a problem. I used to have to print out my prescription when I went to the pharmacy. You don't notice it, but slowly it shifts in the background. And that's what the infrastructure is important for.
So what about Oracle Health, Cerner?
So what about them? I mean, there's a lot to say there. They participate in the health information exchange. They do a decent job. as a fairly modern EHR. That's what I would say in the framework of health information exchange. I think in the framework of like how their business prospects are, I don't know. Do you like Nashville? You see that they're moving to Nashville?
I guess they like country. I don't know. Senator Bill Fist was, I guess, involved with that, right? I guess someone did some lobbying. I don't know. What do you think? Is it a workforce thing? I mean, what tax incentive? I'm sure everyone, where were they once? Were they in California? Is everyone trying to get out of the Bay Area? I guess they can save a loophole. What is it?
Well, I mean, Cerner themselves were based out of I think it's Kansas. Yeah, Kansas City.
Okay, that's right.
But yeah, like Oracle has its roots in California and things like that. Yeah, I think Nashville's a great health town. Larry Ellison's not wrong about that. It is also a fun town, and it's growing, and it's got all these nice things. So that was unexpected. I didn't expect him to say that, but I don't know Larry Ellison. But yeah, I don't see. You could choose worse places to build. Like healthcare community. Just seems like a lot given where they are, since they already have this campus in Kansas City and like everything there. But sometimes change is needed if you want to energize and draw different sort of potential applicants, if you want to get a new energy and break away from sort of like the sad decline that Cerner has been in, then maybe that's the play.
I think it's probably pretty smart because, like Austin, gosh, Joe Rogan should be paid by the city of Austin. I mean, it's like Austin, Texas, or Nashville seems to be like a really popping place for. I mean, you are your talent, your company. So I think it's I don't think Kansas gets people excited like Nashville. Maybe there's other places, but I think if you're building a new company and you want to do some new things, and it is a healthcare place, so it seems like he couldn't go wrong with that. But I really am curious. Epic has their practices, Oracle Health. I'm curious what they're up to, and I know there's no way to totally know, but if you could figure that I'd be curious to know if there's something else sort of that happens similar or that goes on with that happened with the particle, with Oracle. I mean, yeah.
Yeah, I mean, Commonwealth, one of the other networks that Cerner is a big part of, did sort of their own investigation and determined that Particle had done the right responses to not warrant further Commonwealth action against them. So I think they took their look at it and said, okay, well, we're going to continue. We're going to move on because Epic and Care Quality have it covered. But yeah, they're also preoccupied. I think they're preoccupied because they've been on the defensive for a while, Oracle, right? They've got to focus in and say, let's not lose any more ground to Epic. What's our strategy for the future to be not slowly picked away at, which has been the trend. If you look at the class reports and things like that, if you look at the trends of hospitals switching, they got to reverse that or at least stall it. And then they got to find growth opportunities, either domestically and abroad. And so they may not be as outward focused, whereas Epic they've saturated the health system market in the US. So they're thinking internationally and they're thinking about other customer types. They have new programs for payers to be customers. They have programs for labs to be customers. They have programs for even pharma and medical devices, not yet launched, but like listed on their pages. And so they are thinking outward. They're thinking there's not so many hospitals left that aren't using Epic, that are good candidates for Epic. What's next? So maybe that's why.
Fascinating. Well, I don't want to take too much time, but we're kind of coming towards the end. What else do you feel as we're here today is important that we should get out?
I think we covered a lot of the stuff we prepped in the green room. I think, yeah, like if anyone wants to talk or chat about these sort of topics, feel free to reach out to me, Health API Guy on Twitter or Brendan Keeler on LinkedIn. And yeah, I'm appreciative of you having me on, Michael.
Yeah, well, I thank you for coming on, and it seems like you been digging deep on this sort of stuff. Do you do this in your sleep? Do you sleep this sort of stuff, or do you dream in APIs or what?
I definitely do have API dreams. I will admit during my paternity leave as like nighttime lullabies, I read one of the CMS regulations to my daughter. So we'll see how that turns out later in life.
Oh my gosh, that's great. Well, this has been great. Thank you so much. And until next time, friends, on Planetary Health First, I really appreciate it.
Take it easy.